Primary prevention is the cornerstone of modern dental public health, aiming to stop disease before it begins rather than simply treating its consequences. In dentistry, this approach focuses on maintaining a healthy oral environment, controlling risk factors, and empowering individuals and communities through education, behavior modification, and preventive interventions. Among all preventive measures, fluoride remains the most effective, evidence-based agent for reducing dental caries worldwide. Its role in strengthening enamel, enhancing remineralization, and inhibiting bacterial activity makes it a fundamental component of caries prevention strategies across all age groups. Whether delivered through water fluoridation, toothpastes, gels, varnishes, or mouth rinses, fluoride continues to be a safe, accessible, and cost-effective tool for safeguarding oral health at both individual and population levels. Understanding the principles of primary prevention and the multifaceted actions of fluoride is essential for clinicians, students, and public health professionals committed to reducing the global burden of dental caries and promoting lifelong oral wellness. Prevention is defined in 3 stages. 1. Primary prevention, steps taken to ensure disease does not occur. 2. Secondary prevention, promoting early intervention in those already affected to halt progression at incipient stage of disease. 3. Tertiary prevention, treatment of well-established disease to restore function and avoid further episodes. Methods of primary prevention: 1. Oral hygiene education. 2. Dietary counseling. 3. Use of fluorides. 4. Pit and fissure sealants. 5. Regular checkups.
Fluoride in primary prevention. Fluoride has a caries preventive action when delivered in vehicles other than toothpaste. Modes of action: systemic, pre-eruptive effect. Fluoride ions are incorporated into enamel structure in the form of fluorapatite during tooth formation. This decreases the mineral solubility. This one improve crystallinity and crystal size, and decrease acid solubility. 2. More rounded cusps and fissure pattern, but the effect is small. Post-eruptive effects on newly erupted teeth derive the most benefit. 1. Inhibits demineralization and promotes remineralization of early caries. 2. Enhances the degree and speed of remineralization and renders the remineralized enamel more resistant to further attack. Types of fluoride delivery. 1. Water fluoridation. Fluoridation of the public water supply at 1 ppm has been shown in numerous studies to reduce caries incidence. It is more effective against caries on smooth surfaces of teeth than in pits and fissures. 2. Fluoridated milk. Studies suggested that fluoridated milk was beneficial to school children, especially their permanent dentition. The data need to be supplemented by further RCTs, randomized controlled trials, to provide the highest level of evidence for practice. 3. Fluoridated salt. Fluoride gels. Professionally applied topical fluoride used to prevent dental caries and strengthen enamel. Contains high concentration of fluoride, typically 1.2 to 3% acidulated phosphate fluoride. Applied using trays. Contraindications: very young children who might swallow the gel. Fluoride mouthwashes. 0.05% sodium fluoride, NaF, for daily use, preferred. 0.2% sodium fluoride, NaF, for weekly use. Indications: teenager with high caries risk, patients prone to root caries. Dentine hypersensitivity. Contraindications: children under 6 years, patients who cannot spit properly. There is some concern and evidence that alcohol-containing mouthwashes may be carcinogenic. Fluoride varnishes. Contains fluoride in alcoholic solution of natural varnishes, at 2.2% NaF, Durafat. Applied professionally 2 to 4 times a year. Safe for young children, minimal ingestion. Long contact time giving maximum remineralization. Contraindication: allergy to colophony, rosin. Some varnishes contain it. Ulcerative gingivitis, enamel, stomatitis. Fluoride foams. Used in a similar form to fluoride varnish. Promote remineralization of exposed dentine. Contraindication: children who cannot control swallowing. Erosive tooth wear. Fluoride toothpaste. For children less than 3 years using smear size of toothpaste 1000 ppm. From 3-6 years using pea-size toothpaste 1350-1500 ppm. Above 6-16 years brushing twice daily 1350 ppm or above. Adults with active and high caries risk, using 2800 to 5000 ppm. Safely tolerated dose equals 1 mg kg body weight. Potentially lethal dose equals 5 mg kg body weight. Certainly lethal dose equals 32-64 mg kg body weight.
Questions and answers. Which fluoride varnish aggravate effects of enamel? A Durafit, B fluor protector, C bifluoride. The answer is a Durafit. Durafit would irritate exposed connective tissue, causing intense pain and increase the risk of infection. Durafit should only be used in intact surfaces. For children over 9 years, it is recommended to use a fluoride toothpaste to 1,500 million. The answer is false. Children from above 6 years to 16 years should use toothpaste 1350 ppm or above. A 25-year-old male attends for the first time complaining of sensitivity of a number of teeth. On examination, the occlusal surfaces of all the teeth are worn with obvious wear facets on the canines and premolars. Posterior amalgam restorations are proud of the surrounding tooth. What would be the first stage management? The answer is D. The first stage of management is dietary analysis.